I want first to say that that meeting in back several years ago changed my life in a way that really kind of made me realize how much suffering and how much negligence we have practiced as a society by not only acknowledging and embracing and caring for the vaccine injured, and in this particular case, the COVID vaccine injuries, of those people that really trusted the system and actually went ahead and vaccinated. And not only that we did not embrace them, we did not take care of them, we actually gaslighted them, ignored them. We have to look to ourselves as a society in the mirror and really kind of think to ourselves, how did we make those kind of actions where we were so lacking empathy, lacking ethical, basic ethics, basic humanity to be so cruel to these people. And I think that once we demonstrate to people that we are now serious about going back and studying this, they would start trusting that we are at least trying to understand the truth and trying to do what is best for the health of people, and not trying to protect some interests of some pharmaceutical companies or interest of some decision makers that made maybe mistakes in the past and made some wrong statements in the past. So we only are focusing on finding the truth. So we need to give them hope. That's to me the most important thing, that they know that someone is working hard to find care for their problems.
Welcome to the React 19 podcast, where we bring awareness and support to the COVID-19 vaccine injured and discuss the science, research, and laws that affect all of us. Hi, everyone. Thanks for joining us again today. I'm Ann Forty, the host of the React 19 podcast, and it is a privilege to welcome today's guest, Dr. Retsef Levi. Dr. Levi is a distinguished professor of operations management at MIT's Sloan School of Management. His expertise lies in advanced analytics, risk management, and data-driven decision-making, often applied to healthcare systems, manufacturing of biologics with pharmaceutical companies, and public health logistics. And today we'll talk about what all that means for you and me. Dr. Levi was recently appointed as a member of the Advisory Committee on Immunization Practices, also known as ACIP, and serves as chair of the COVID-19 Immunization Workgroup, which is reviewing evidence on the safety and effectiveness of COVID vaccines. Dr. Levi, thank you so much for being here today.
Thanks, Anne, and thanks for the opportunity to chat with you, and I look forward to having a good discussion.
Yes. Well, before we get into your recent work with ACIP, I would like to start where many of us first came to know you, because I believe it really speaks to your integrity and your courage. Back in November of 2021, you spoke on an expert panel about federal vaccine mandates. You raised concerns about the extreme narratives surrounding the pandemic policies and really the hostility faced by anyone who questioned them. You even shared that a close, like-minded colleague who held a very prominent position warned you to, quote, be careful because you could be eliminated, meaning your job. Yet you chose to move forward with courage and speak on that panel. And during that meeting, you heard many heartbreaking stories from the vaccine injured, including Ernest Ramirez, who lost his 16-year-old son 5 days after receiving the Pfizer vaccine, 12-year-old Maddie DeGarry, who became paralyzed after receiving hers, and you listened to co-founder of React 19, Bree Dressen, who was left permanently injured after her vaccine, read a letter from a vaccine-injured friend who committed suicide because they lost all hope of ever receiving help. And unfortunately, that has continued to happen. You said those stories inspired you to move forward with courage and determination to find answers and better ways to help the injured, which really brings us to where you find yourself today, heading up the ACIP working group on COVID-19 immunizations. So If we could start by talking about how your education and training make you uniquely qualified to serve on that ACIP committee and the working group. And I believe, quite frankly, it's because of your broad understanding of how complex systems work, which I think gives you the ability to see the bigger picture and ask kinds of questions that others might overlook. So tell us what we need to know to understand what you do.
So thanks, and I want first to say that that meeting in back several years ago changed my life in a way that really kind of made me realize um, how much suffering and how much negligence we have practiced as a society by not only acknowledging and embracing and caring for the vaccine injured, and in this particular case, the COVID vaccine injuries. Of those people that really trusted the system and actually went ahead and vaccinated. And not only that we did not embrace them, we did not take care of them. We actually gaslighted them, ignored them, and that day kind of left me with kind of a internal decision that I cannot just like look the other way, and I have to do whatever is in my power to speak up, as little as this might be compared to the suffering that I've seen, but just do whatever I can do to make sure that this is being corrected. And the reason that this needs to be corrected, absolutely, and as sooner than later, is not just because it's unethical. It's grossly unethical, but frankly, because it's really a fundamental aspect of being able to have trusted public health policies and in particularly trusted vaccine programs. Because the idea behind vaccination programs is that we are asking people more often than not to take an individual risk, not only just to protect themselves, but also to protect the others, to protect all of us as a society, right? And that has to come with a absolutely commitment to basically care for those that were unfortunate and were injured. Because otherwise we are undermining the very core idea of a vaccination program and the ethics that stands behind it. So I believe that actually that the more pro-vaccine you are, you have to even worry about this more. And the way we handle this is, as I said, is so far away from what it should be. Yeah. That it made be on that day. I remember being both sad, angry, and full with anger, and a strong sense that this is something wrong. That I have to do whatever I can to try and help fixing. So,
and you're doing just that.
I'm trying. It's the work of many that will be needed to change the situation. But back to my background. So I'm maybe my life path is somewhat non-traditional. So I did not start as an academic. I was born in Israel and started as quite a long career, almost 12 years in the Israeli military as an intelligence officer. So I was trained for many years to look on complex systems through multiple streams and modalities of data and information and try to understand how they work in the context of intelligence. Then when I was 31, only, I finished my bachelor degree, so quite delayed, definitely to if I compare it to the US kind of norms. So I finished the bachelor degree. Again, I did it in two pieces. I started 1 year and then they called me back to the military for another 2 years. So I finished the bachelor degree in mathematics with the trend in operations research. And at the age of 31, decided that it's the perfect time to take my family at the time. Then I had two kids. Two of my six children were born already. And we came to the US, to Cornell University, upstate New York, Ithaca, to do a PhD in operations research. And operations research is a discipline, it's an academic discipline that developed since the World War II, and it's concerned with how to use data and modeling and advanced analytics to uh, capture the dynamics of very complex systems that operate under a lot of uncertainty and try to optimize their design and operations by building models and using data that can provide decision support tools to the decision makers. So it's really about trying to capture complex decisions.
Right.
And that often involved a very nuanced balance between risks and benefits and different objectives and so forth. And when I started my PhD, I never imagined that I will, even then, I did not imagine that I will be an academic, but I ended up at MIT, on the faculty at MIT, and I'm here from 2006. And broadly speaking, my research is exactly focusing on these complex systems that operate under a lot of uncertainty with a great consideration to risk. But a lot of my work have been, it was quite broad and it touches many application domains, but a lot of my research work has been focused on human health from different angles. So I've been working for almost 20 years now with large healthcare systems, working with physicians and clinical teams to try and optimize clinical and operational processes and systems within large hospital systems. I've been working on issues related to manufacturing of biologic drugs and how do you think about safety and quality of those, epidemiological models, drug safety models, post-marketing pharmacovigilance models, but also issues related to access to healthy food, food safety. So different angles that think about human health. And as you said, I'm usually trying to really understand how these systems operate and understand the mechanistic nature of those systems by using data modeling and domain knowledge that are quite diverse. So in order to apply operations research, you typically have to enter different areas and learn their kind of specific knowledge domains and be able to integrate that with data and modeling and with what kind of decisions people have to make in that context. So you're gonna be able to really provide some meaningful insights and develop some practical decision support tools. And my research was done quite extensively in collaboration with industry and government partners. And by now, I have more than 20 use cases of work that I've done as an academic that were implemented in the field and are actually being used and with impact assessment. And I believe that we maybe kind of got used to think about vaccines and thinking about risk and benefits of vaccines as something that belongs only to biostatisticians and to medical doctors or people that understand virology and vaccinology. And indeed, these people have a lot to say about the related issues, but I also believe that we need to have broader perspectives, and we need to really, at the core, what we need to understand here is our risks and dynamics of very complex systems, and how do we understand the data that is being collected on them, and how do we leverage that to inform various nuanced decisions. And I think in that respect, people with my expertise can actually contribute and bring to the table maybe some unique perspectives.
Yes, thank you for mentioning that because I did want to ask you that question. So you've already addressed it in that, some people have said, oh, well, what does he know about immunology or vaccinology? And I think you've explained very well that what you bring to the table is something that those, individuals may not have. Again, this broad understanding of systems and
Yeah,
that risk.
and let me just make it much more concrete, if I may. So if you think about vaccination and the use of vaccines. There are so many aspects to this. So there is the aspect of understanding the disease and the threat that the disease poses to different subpopulations, depending on their age, health status. There is the notion of understanding what kind of risk can come from the vaccine mechanism or mechanism of action and how it impacts the human body, but also mechanisms of potential risks that come from the manufacturing, right? And then you need to take all of this and also imagine of how things are being practiced on the field. So how, for example, these vaccines are being administered, how, for example, vaccine injuries will be likely treated in a healthcare system, especially or in situations where maybe the symptoms are not specific and do not fit a diagnosis. So all of these nuances are things that in order to integrate them, you need many, many perspectives to be brought together. And that's why you need actually people from various perspectives to be on the table when you discuss that. But maybe one of my advantages is that I've actually had experience with many of these perspectives myself. So I may not be the best expert in epidemiology or the best expert in vaccinology or the best expert in biology, but potentially I'm able to integrate and really kind of bring it all
together.
To one systematic view, or at least help with that. So
Right. Well, let's talk specifically about the work you're heading up within the ACIP work group on COVID-19 vaccines. I know you want to focus on research and gold standard science. And just so everyone is clear, ACIP's role is to advise the CDC on vaccines. It can make recommendations whether they believe a vaccine is safe or not so safe. The CDC then decides whether they want to recommend the vaccine to be put on the schedule. So although ACIP is only giving recommendations on vaccines, you are very involved with researching the data on them. And here's where I would like to camp for a minute, because I'd like to ask the question on how do you even begin to do any kind of meaningful research already knowing that the data you have is either incomplete or simply wrong? And let me give a couple of examples of why I say that. There were many vaccine injured who were coded as unvaccinated, who in reality were vaccinated, so their harms would not even be classified as vaccine injury. I was just texting with Heather Hudson last night. You may know about her son Cody. He was fully vaccinated. He's dying. He's dying because he's waiting for help that he can't get. But at any rate, he'd gotten his 2 vaccines, and the hospital, all his records show him as unvaccinated. Same thing happened to Henrietta. Her son died of an aortic dissection. He was fully vaccinated, but his record says unvaccinated. So that's one issue. Another major issue is the lack of ICD-10 codes for vaccine injury. And for those of you who don't know, an ICD means an International Classification of Disease. And back in November of 2022, React 19 petitioned the HHS and CMS seeking to get an ICD code for vaccine injury. And within 6 months of that request, an ICD code was assigned to vaccine hesitancy, underimmunization, unimmunized, immunized partially, and there was also an ICD code issued for long COVID and subcodes for that. But there is still nothing for COVID vaccine injury. So this has huge implications, because how do you even begin to find the vaccine injured? And without those ICD-10 codes, the injured lack acknowledgement, diagnoses, have problems with billing and reimbursement. And again, you have difficulty in doing any meaningful epidemiological research and study. So where do you even begin?
Thanks. So you asked kind of a very, a set of very involved and complex questions, but let me start by saying a few things. So I think that the way we approach the work group on the COVID immunization in its current iteration is in some sense transformative to the traditional view of what ACIP role and scope of work is. So I think it's fair to say that traditionally people have viewed ACIP as basically thinking narrowly about specific policy questions, whether to recommend or not recommend a vaccine or immunization product, and to which groups it should be recommended, what timing, and more often than not, it was very narrowly defined a policy question. And in most cases, it was also clear what the answer is going to be, what the recommendation is going to be. And also, frankly speaking, the data that was brought to bear to kind of assess those um, um, questions was primarily CDC data that in a second, will talk more about what I think is missing. So we took a very, very different approach. And we basically said that our scope and our charter is to broadly think about all the relevant issues to vaccination policies, including in particular, and that's kind of appearing in our terms of reference document, if people can actually read it online.
Yeah, I'll
But
put that in the show notes so people can look at it.
we are actually saying there explicitly that we are going to look broadly on all the available information in scientific literature and the clinical literature including clinical experiences. And one of the things that we set up ourselves to address was mapping vaccine injuries and thinking about the overall system that we currently have to surveil vaccine injuries, to recognize them, to identify them, to study them, to diagnose them, and so forth and so forth. So that's kind of something we set ourselves to do from the get-going, exactly based on the understanding that when you think about vaccination policies, it goes well beyond a narrowly defined question about whether you should use a vaccine or not. It includes a range of policies, and one of the domains that you need to worry about, am I having the right system to identify injuries, to identify injured people, to care for them, to diagnose them, and so forth. And so that kind of was the terms of reference, but we didn't just stay with the statement. We actually brought to the team, to the work group, multiple physicians that are actively engaged with caring for vaccine injured individuals at the moment, with the premise that we're going to rely on their experience. And as I mentioned in the last ACIP meeting, when we discussed the COVID vaccine, we addressed some immediate policy questions, but we also started to work on various other topics, one of which, and I already kind of presented that in the last meeting, with a commitment to come back to ACIP with a comprehensive set of recommendations that will address exactly the questions that you raised.
Okay, so one
Let
of those.
me kind of elaborate. So I think that more broadly, when I think about the current paradigm that we have when we think about safety of vaccines and in more specifically injuries from vaccines, I think we have a broken paradigm, and it's broken on multiple levels. The very first level is, and that's a little bit of puzzling contradiction, that while we usually give vaccines with the premise that they bring long-term value in the sense that they're going to change your immune system, in most cases, sometimes for life, but some prolonged period of time, and will provide some long-term protection against the virus or bacteria, right? For some reason, when it comes to safety and injuries and harm, we have an implicit assumption that all the harm has to happen within a very short period of time after the vaccine is given. So that's kind of one thing that I think that it's kind of contradictory in my mind, and I think we need to expand our vision to basically look on long-term benefits, long-term harms side by side, and really compare them. Now, the other thing that I think is very important to highlight here, and I think you alluded to that, but I want to kind of formalize that, and that's kind of maybe coming back to my own background, because you see, most people, like including many statisticians and biostatisticians that are very brilliant in analyzing data, may not ask themselves enough how the data were created.
Mm-hmm.
What are the limitations
Right.
of that data as a result of that? Like, so for example, you mentioned that the issue of lack of diagnosis. So the point is that most of the safety data that we are currently looking at is based on what doctors code.
Right.
And what kind of codes they use. So to your point, if you understand that there is not sufficient or no codes at all, right? Then you have to assume that basically your data is not going to capture the things that you're trying to measure.
Right. Right.
So you have to solve this problem and accommodate and incorporate that kind of understanding into how you actually perceive and interpret the existing data. Now, worse than that, I think that, and there's actually some recent papers about this that really suggest that whenever the injuries from vaccines are long-term and manifest themselves with non-specific symptoms that don't fit to an existing diagnosis, and in the absence of diagnosis guidelines, the chances that these people are going to be characterized as vaccine-injured people is essentially zero. And that's actually what we see on the ground. We see a lot of people going from one doctor to another, not being
Exactly.
diagnosed until they get to the very few, a handful of physicians that already have some experience. But even those physicians often struggle because they
Right.
don't have commercially available diagnostic tools. We don't have common learning. We don't have investments in research for
Right.
therapeutic. So it's all being done based on the goodwill of a few, of a relatively a few. And I think we need to change that.
Yes.
We have to change that. And that's something that I'm committed and the work group is committed to come back with a set of recommendations that will include comprehensive analysis of what are the diagnosis codes that we need to have. How do we construct diagnosis guidelines that are being communicated with physicians? How do we share knowledge among physicians, both on the injuries that we see and the potential therapeutics, right? How do we create availability of commercially available diagnostic tools that are appropriate to diagnose these patients? And then how do we invest in treatments? Because as a result of not having that data, it's hard to estimate the scope of the prevalence of the injuries, but it's definitely not rare. For whatever people mean, but I'm in general, I'm very reluctant to say rare because rare is a very ambiguous, vague term. I think we need to assume that that's a real phenomena that is maybe more common than we think. And we need to really put in place the system that, and I kind of outlined some of the key components to be able to diagnose in a timely manner, use the appropriate diagnostic tools and diagnosis guidelines, and then invest in treatment. And by the way, potentially in some cases also do active surveillance. So let me just give an example. Myocarditis is a known kind of one of the maybe only known acknowledged side effects of or adverse events of these vaccines. But frankly speaking, even in that context, I think that there is a lot of downplaying of the true risk, both in terms of the nature of the outcomes as well as the prevalence. So even now, despite of quite vast documentation in the literature of cases of deaths, including of young people, including young children. And I actually covered this in my presentation in ACIP. There's documented cases in the literature of kids that in all likelihood really passed away or died because of myocarditis induced by the vaccine.
Right.
And again, this doesn't mean that you should not use these vaccines, at least on some people, because still the risk and benefits can maybe justify using some vaccines for some people. But that doesn't say that you have the right, or is it right or justified scientifically or ethically to deny the fact that there is a real risk here of death. Now, even with respect to the frequency and the prevalence of this condition, we currently focus very much on what is called clinically diagnosed myocarditis. So these are all the people that showed very, very clear symptoms, were diagnosed, and were clinically determined that they fit the diagnosis of myocarditis. We know for myocarditis that, and we actually know that from long-term knowledge, medical knowledge in other settings, including, for example, the smallpox vaccine that historically also caused the myocarditis. We know that for every clinically diagnosed cases, there are many other cases that are either have no symptoms or had vague symptoms and they were not clinically diagnosed.
Mm-hmm.
And we actually have two studies on the COVID vaccines, the mRNA vaccines, where the hearts of young children and young people were tested before and after, immediately before and immediately after vaccination. Mm-hmm. And in about 2 to 3%, you saw evidence of elevated troponin, which is the hallmark biomarker for heart damage, muscle heart damage. And if that's the case, then and given all the number of doses that we gave and multiple rounds of boosters, we might have a situation where many people are going around us with heart damage of a certain kind, that the prognosis is not clear, and they are not even aware that they are harmed.
Right.
They might actually find themselves in some very serious adversarial situation, because we know that subclinical myocarditis is a serious reason for sudden unexplained cardiac arrest death. So my point is, we need to address this, and we cannot just look the other way just because we don't want to acknowledge some harm, because the public health and the health of the population is important enough that we need to go and really consider whether we need to do some proactive surveillance here. So again, I think there are many elements to that. Similarly, there are some concerns about these vaccines potentially enhance cancer or maybe cause cancer. Again, very partial information. We cannot establish causal links yet, but there's enough concern that I think we need to have national autopsy program. So these are all elements that I believe that ACIP, within the scope of ACIP, and that ACIP should consider, again, without speculating what are we going to recommend, but ACIP should consider these topics as central to its core mission, and should do analysis about that. And if the work group and then ACIP will find it appropriate, then I think it's going to be legitimate to recommend to the CDC director and the Secretary of Health Services, Human Health Services, that, okay, these are the things that you need to put in place to address all of these gaps. And for sure, and I already kind of mentioned that in the last meeting, for sure we have commitment to do that in the context of vaccine injuries and the vaccine injured.
Yes, I'm sure that is just such a refreshing thing for so many of the injured to hear, because they just go. I talked to a woman yesterday. She was completely healthy. She has her vaccine, and her doctor doesn't know she's gone from having vision issues and then rheumatoid arthritis and then neuropathy. Now she's having heart issues. She's on 15 different medications, prescriptions, and 12 different supplements. And she's never been classified as vaccine injured. And how do you find her? So yes, I think you know the issue.
It's going to be a long process, and I don't want to, the vaccine injured, I have personal commitment for this topic. I feel that many of the work group members in our work group have deep commitment for that. But I also want to be realistic. Unfortunately, this is going to likely be a slower change than what is needed, because the nature of life and the complexity, and we really are fighting uphill battle here. From a situation when these people are gaslighted and completely ignored, to, how do we get to a place where we appropriately addressing that? So I don't want to overpromise and overstate. I want to be humble and realistic that we're going to do our best, but the change is going to likely be gradual. But hopefully we're trying to push in the right direction. And I recognize that we need some dramatic changes, and we need them as fast as possible. But I also want to be realistic and be candid that there are no magics here. Like we will not be able to change reality instantly, unfortunately. So,
You know, during all of this, React 19 has remained patient-centered with their three pillars of compensation, because we know the CICP has completely failed them, clinical care, and research. And all three of these have been born out of the necessity in the shadow of multiple government failures. And compensation, React 19 has awarded over $1.3 million just from people sending in $20, $30 here, because everything that comes in goes right out. They built a provider network with nearly 600 providers nationwide and has participated and collaborated with institutions like Yale University in Baltimore, Maryland, UCSF. And do you see a role in the future advancements of science with patient organizations like React 19? I mean, there's all these injured that would love to be studied, and do you see that ever happening?
so yeah, so let me just react to a few things that you said. First of all, I think that I understand why compensation is important, but in my mind, the most important things are uh, investing resources in diagnosis in therapeutics, because frankly speaking, most of these injured people, no money is going to give them back their life and their quality of life. So we need to give them back their quality of life. Money is important, but like, money doesn't help you as much if you are completely lost your quality of life and you are hopeless, right? So we need to give them hope. That's to me the most important thing, that they know that someone is working hard to find care for their problems, right? That's one thing. But the other thing that I think, and the compensation is including that, but I think that more important than the compensation is the acknowledgement. I think that one of the cruel things that I find it cruel, is that, I mean, you mentioned Ernest, him him talking to on his son, that um, every time I think about him, I'm on the verge of crying, and I actually cried on that November meeting, because it's so heartbreaking. But to me, the fact that even now nobody formally acknowledged
Mhm.
that his son died from a vaccine injury, that's wrong. And I think there are many people like Ernest, that them or close one to them were injured, and they know, they were not, and there is some gaslighting and no acknowledgement. That's wrong. I just think that that's kind of, uh, we have to look to ourselves as a society in the mirror and really kind of think to ourselves, how did we make those kind of
Right.
actions where we were um, so lacking empathy, lacking ethical, basic ethics, basic humanity, to be so cruel to these people. That all they did is just listen to what they were told, right? Like, and some people even call them anti-vaxxer, which I find like, how is it even possible, right? So to me, there is a deep moral issue here. So I think the acknowledgement here is, and I hope that the government, the regulatory agencies will do more around that, because yes, compensation is important, but I think that these people first look for acknowledgement, and second look for help, actual help. And I don't think that money is the best help. Yeah,
Well,
it's important. It's an important component to help with healthcare expenses, to help with all. But the most important thing that we need to give them is hope that we are working hard to help them get back at least some of the quality of life. And we need to give acknowledgement, right? And yes, the money is also important. Uh, I don't want to underestimate that, especially because many of these cases, people lost their ability to make a living, and they have tremendous healthcare expenses, right? Um, but I think that I just want to make sure that we don't think that we just need to throw some money on the problem and it's going to go away. That's not going to be, that's maybe
right.
necessary, but not sufficient. That's what I'm trying to say.
Yes. And I do think it's important for people to also you're right. It's not an either or, it's a both and, because some of these people, yes, they have lost their entire life savings, everything. They've lost their homes. And the only way that they're being able to stay alive is through, maybe IVIG or, some off-label things. But if they can't get money for that, they are literally going to die.
So
And
what we
so,
need to do is to make these things available in a more affordable way rather than
yes,
going off
yes,
label. So my point is we need to
do
develop
both.
rigorous, structured care paths, therapeutics, and fund those, right? Rather than throwing them a little bit of money that is not going to. I'm pretty sure that whatever money people will throw in that direction, it's not going to be sufficient, nearly sufficient to cover the long
Exactly.
life. So I think we need to do much more on the A. Like these are therapeutics that we need to put under insurance coverage. These are diagnostic that we need to put under insurance coverage. All of this needs to be covered like a regular condition, a medical condition. We have new medical
Exactly.
conditions. We need to start treating them like that, and making this affordable, and not like putting people in a position when they need to spend their entire income and assets on being in hopeless and lost in some
Exactly.
journey when they are alone. So
Exactly. So do you see any room where, React 19 could be involved with some of this research with all of their
absolutely,
members?
I think absolutely. I think that the I think that the premise that we took on the work group was that we need to listen to people in the field and
Mhm.
listen to their experiences, and that includes the patients, and that also includes the people that care for these patients now. And we need to listen to them, and we need to kind of use their insights and their kind of knowledge and their experiences to inform how do we formulate what the problem is, what the problems are, and what could be some solution approaches. In general, I think that in the area of vaccines, and especially vaccine injuries, we have been very, very lacking in our ability to listen to injured people or to people that feel that they're injured. And we kind of dismissed a lot of these um, inputs and experiences as anecdotal or like, oh, imagining. I think there is nothing more wrong than that.
Hmm.
Again, it doesn't say that every story is necessarily a vaccine injury.
Right.
No, I'm not saying that. Like,
Right.
but I've been saying that ignoring those experiences, ignoring those inputs, is wrong on so many levels. It's wrong on the empathy level, and it's wrong on the moral level, but it's also wrong scientifically because these are the inputs that you should be using to formulate your hypothesis, and then you go and validate them in other ways and inform what you're doing next.
Right. Moving forward, it's so hard. There's so much information out there and, coming out of even, our health agencies. Now, I want to give an example of this where, people want to be able to start trusting, maybe what's going on at the FDA, the CDC. Well, on Tuesday, I just pulled this before our interview. The National Academy of Science and Engineering and Medicine, that's NASM, they put out their report on its evaluation of the Immunization Safety Organization, ISO, of what happened during the pandemic. And they basically said, oh, yes, there were robust, we captured, injuries and we did all this. Well, the person who was in charge of that was Tom Simbakuro at the time. And I just want to give an example of what Tom Shimbakuro, what his mindset was. So there were people who were trying to let him know about injuries. I think he was either an engineer or a pilot, and he'd gotten all this information together about tinnitus and all these injuries, these adverse events he had had. He had given them to Tom Shimbakuro's office. And this was Tom Shimbakuro's response. And I have the email, copy of his email. He said, thank him for his email and cut him off. And we were just told on Tuesday by this NANSEM report that this office of ISO, yes, we covered these injuries and it was robust. And that's just it makes you lose even more trust that this is still where we're at. That, we just got a report on Tuesday saying, oh, yeah, what we did was great. But here's the man who was in charge of it saying, oh, cut him off. We don't want to hear it. And so I guess my question to you is, are where would you lead those to look to what's really going on? I think, or I think you've talked about the Doshi and Freeman where they were reporting 1 in 800 injured. Is that something we can trust? Where would you have people start saying, "Hey, start looking here"? Where can people go for trustworthy information?
Okay, so first, I didn't read yet this report that you mentioned, so it's on my to-do list in the next several days. Um, but I think I shared with you before that my perception is, or my opinion is, that the way we think about vaccine safety is broken.
Mhm.
Um, and I mentioned a few reasons why, or a few aspects where I think it's broken. I also think that the entire narrative that leads us is wrong. And my favorite analogy is well, when you're sitting in a plane just about to take off,
Mhm.
and the pilot suddenly sees a blinking bulb, and now debates between two approaches, right? One approach says, okay, I don't know for sure that that's a problem, right? Let's just take off. Versus, oh, I have to absolutely make sure that it's not a problem before I take off. I think that most of us will most definitely want the pilot to take the second approach.
Mhm.
Yet when it comes to vaccines, and even ones that we give to healthy people or healthy babies or healthy children, we somehow take the first approach. Let's just take off because we don't have evidence.
Right.
And that's like despite of very limited kind of systems to measure the harm, that some of them are the result of choices that we made and maybe wrong choices, and some of it is just the nature of the limitations of the current systems that we have. And so I think that what you're describing is, and this also kind of narrative that we create these limited systems and we only listen to those systems and we don't listen to anything else,
Mhm.
created a situation when the narrative that traditionally came in the last several years from the CDC, that these are safe and effective vaccines, the mRNA vaccines are safe and effective. The only thing that they have is mild myocarditis. It actually broken. It was one of the major reasons why the trust is broken, because servers suggest that a very large fraction of the public believes that either themselves or someone close to
Mhm.
them were injured by this
Right.
vaccine. So this gap, I think there are many reasons to fix the problems that we currently have. But if anything else, if nothing else is convincing to you, the fact that you are in such kind of major chasm
Hmm.
between what you say and what people actually believe, uh, this is not sustainable. You're going to
Right.
lose. You're going to so and unfortunately in life, breaking things is much faster than building, rebuilding, and building.
Right.
So the journey to rebuild trust is going to be long. And I hope that the work that the new ACIP members are doing and will do is going to help at least a little bit with building that trust. Now, what do we do in the meantime? So in the
Hmm.
meantime, I think we need to keep asking questions, keep looking on the entirety of the evidence, and be humble, not to jump and give very kind of confident statements. Oh, it's safe and effective. Just be humble and really kind of build a system that will allow us to measure. Because currently, I don't think we have the system that will allow us to measure. So we will have to investigate and sort of see what is the scope of the injuries. And I'm not sure I have an answer to that. As I said, my hunch is unfortunately that it's not that's quite unprecedented in terms of if you compare it to other vaccines, right? But I think we will need to go and invest and study this. And I think that once we demonstrate to people that we are now serious about going back and studying this,
Hmm.
they would start trusting that we are at least trying to understand the truth and trying to do what is best for the health of people, and not trying to protect some interests of some pharmaceutical companies or interest of some decision makers that made maybe mistakes in the past and made some wrong statements in the past. So we only are focusing on finding the truth and helping people to become healthy again. If we are able to commit to that consistently, I believe that the trust will follow.
So, can I just ask? I mean, it would be so reassuring to know everyone on that committee thought just like you did. Do you think the majority of people you're working with have your same mindset? I mean, because if they do, then we will get to truth.
So
Um,
okay, I don't want to speak. I mean, I don't want to speak too much in name of my colleagues, but like, um, I think if you look on the votes, right, uh, the votes were either unanimous or almost unanimous, and one of the votes, and that, again, that's kind of a precedent. It's a big precedence.
mhm.
We actually recommended to the CDC that they need to change the language of the vaccine information statement. This is the document that describes the risks and benefits of the vaccine, of the COVID-19 vaccines. And this is essentially the major document that is being currently used for informed consent. We explicitly asked the CDC to add language to that document that speaks much more candidly in a way that I think is much more aligned with the reality and what we know about the existing risks and existing uncertainties that we currently have about the impact of these vaccines. The questions that we have and the uncertainty that we have about their benefits, the fact that you can actually die from myocarditis, the fact that the spike can actually persist in the body and that components of these vaccines can be distributed across the body and stay for a prolonged period of time. The fact that there are vaccine injuries. All of this, if you actually go to like 6 items, this was approved almost with almost uniform vote, right? So I think that people feel very strongly that we need to be transparent about the risk and benefits. And that transparency is absolutely critical for the ability of individuals to make choices in consultation with their physicians and medical providers. Both need to have transparent information in order to make those joint shared decision-making choices about their own body, right? And so we believe that because one made these injuries worse even, right? The fact that many of these people were mandated to take the vaccine
Yeah,
in order to
right.
keep a job, right? So we do not believe, I think that in general, we do not believe in mandates. We believe in individual choice that is nuanced to the personal situation of the patient, the risk and benefits of the patient, and the core interaction between the patient and the medical provider, given accurate and reliable information. And that's kind of, I think, a sentiment that this group is very much bought into. And that is very different than maybe the
Yes.
past narrative. And speaking to that, we already kind of started to demonstrate that in the context of a COVID-19 vaccines, where we basically, for the first time, I think it's an historic decision in many ways, that ACIP is making a statement about, okay, these are the risks and uncertainties that need to be communicated to patients and physicians so they will be aware of them. But one of the byproducts of this is that there is the first time we acknowledge these risks whatsoever. These risks and uncertainties were never acknowledged by a government agency. And this is going to be the first time that they will be acknowledged. Because I believe that actually this recommendation was also accepted and was approved by the CDC. So this is going to be in my mind, the first step in a pivotal change of we're going to start acknowledging and catch up with reality, and we're going to be candid, and we're going to be transparent, and we're going to be empathic, and we're going to do the right thing. I believe in that, and it's going to be a long journey. And I'm not going to sit here and promise that we'll be necessarily successful in what timeline, but I can promise one thing: we're going to work as hard as possible to move things in the right direction. And I personally, I can tell the injured people that the November 2nd meeting and the people I've met there and other people that I've met are in my mind and in my heart every single moment when I work on these issues.
It is just so, I feel like for the first time, wow, there's hope. And so I know everyone at React 19 appreciates your voice. I mean, we saw your courage 4 years ago at that, and here you are. And so I just want to say thank you so much. I have so much more I could talk to you about. Maybe we can do another interview in the future where you can keep us updated. But I know our time is up. Where can people follow you? Where would you recommend that they keep up with you or the work that you're doing?
So first, thank you for the kind words, and I just want to say that the real courage of the people that are really facing the hardship every single day and their families. That's a kind of adversity that uh, really test your resolve and test your courage. And I admire these people, and what I do and others is just like a little bit that we can do. It's not comparable to the suffering and the courage that these vaccinations.
100%.
So I think I'm on X. People can follow me there. And ACIP is all the discussions are publicly recorded and publicly available. So that's another place where people can see, and I invite them to watch the last meeting, because I think there were a few things that give some hope, and I'm hopeful. I know that we have a lot of hard
A
work
lot of work.
to do, and I think we are just at the beginning of the journey, but we are determined to move in the right direction.
Well, Dr. Levi, thank you so much.
Thank you. Enjoy the rest of the day.